Everybody's a little boisterous here after being cooped up for 2 years. Well, our visiting professor, Griswold lecturer for this year, had a family emergency, Dr. Spain, and fortunately could not come, and we'll have him back another time. Dr. Jason Smith has graciously agreed to give a lecture on a topic that, interestingly enough, has been requested time and time again by our residents as something that we don't talk enough about. So, about the business of medicine. And he's going to talk about how you get paid. The students are thinking, wow, I'm going to get paid. I haven't had that in a while, but probably not going to get paid. But eventually you will. And the residents are thinking, I don't get paid enough, and how do I really get paid? So pay close attention. Dr. Smith got the big introduction not long ago, so I'll forego that and take it away, Jason. Thank you for filling in.
All right, good morning, everyone. So I gave this lecture to our AAST trauma fellows earlier in the year. I give this about every 2 years to the people that are going through the trauma fellowship. And I realized I hadn't actually talked to you all about some of the things in here. So this is going to be a little bit of everything. There's a little bit of history because I've got to teach you something. And then we'll talk about a few others. I used to say that I was not an expert in this field. However, over the past 2 years, I've looked at nigh on 1,000 physician contracts. I'm now considered an expert in this field for whatever that's worth. So we'll talk a little bit about the healthcare reimbursement system in the U.S., why it's important. We'll talk about how hospitals and healthcare systems is compensated, and then we're going to talk mostly about how physicians, surgeons, and other providers get compensated. And what are some of the terms we talk about? When I say RVUs or ICD-10s or CPTs, what does that mean? And so that'll give you an overview. And I think that's the most important part of what I'm going to tell you today. This is an overview. You could spend hours talking about contract negotiations, what you look for in a job, what you're trying to do. But what I want to do now is simply try and familiarize you with some of the terms that we're talking about and what we're going to be going through and what you need to know as you go through these things. Master's actually made it brighter up here. So let's talk about the elephant in the room. Physicians do not like to talk about money. And I guarantee there are people in the audience right now that are cringing that I'm giving you a topic about finance, okay? Let's make one thing clear. Making a living and getting paid is not wrong. That's why we go into this field. For lack of a better term, if you were going to do this for free, we wouldn't go through all the school and everything else. But we're a highly resourced individual. We spend a lot of time to learn these things. We dedicate a lot of our lives and our time away from our families to take care of patients, and there's compensation associated with that. So, number one, you need to step away and realize that at the end of this, when we're all said and done, you're going to get paid, and you need to understand why and what that's worth. The second thing, the other elephant in the room, is doctors are really bad with money. If you don't realize that, you need to realize that now. And the reason for that is the first elephant in the room, we don't like to talk about money, all right? The second problem with that is we will throw everything out the window to do the right thing for a patient, for a person, for our families, for whatever, because that's the way we're trained. That's the way we're built. That's why we went into this field. And what we need to realize is just take a breath and step back and think, okay, this is the way I am. There's nothing wrong with that. That's what makes you a good surgeon. That's what makes you a good physician. But you have to realize that when you start talking about things. Okay, so why now? And I think the most important reason that we need to start talking more about this in education and more about this with residents, fellows, and students is we are at a crossroads in the American healthcare system, okay? And the path that we take is going to be nice or it's going to be very rough moving forward. And COVID has only slightly delayed or changed that path. And I think that's the other thing that I get asked a lot about is I gave this talk, 5 years ago. And then the questions I got is how did COVID change this? And COVID did not change this. If anything, it brought into stark reality many of the problems we have with the healthcare system, but it also only slightly delayed many of the changes that we are going to see moving forward. Let's talk about the big picture trends in healthcare, all right? National healthcare spending in the United States will be somewhere around 25% of the GDP of the United States based off of current spending by 2040. That actually increased to 2036 because of COVID. So we have spent an immense amount of money in the last 2 years around the healthcare system. Is that good or bad? I don't know, but it is simply what it is. And so what we need to realize is that is not sustainable. When 1/4 of every dollar spent in the United States for any purchase goes to healthcare and healthcare related activities, the other thing you need to realize is this doesn't go to hospitals and physicians. This goes to the bottom line of insurance companies and everywhere else. That's a problem. We also spend more than most other countries in the world. If you look at it, Switzerland is only slightly close to us. Switzerland, for those that don't know, has a hybridized system where they've got a private pay system for many commercial insurance companies. They have that part of the system. It's the way it was built. The United States spends more. But unfortunately, the United States life expectancy is not on the same path as many other countries. And there are a multitude of reasons for this. Not all of this is related to healthcare. But the simple fact of the matter is we spend more per person in the United States for healthcare, and we get less for that dollar spent than you do in other areas. Let's take a look at where we rank in many of the categories in the United States compared to other countries. Life expectancy, Switzerland is actually one of the highest. All right, there's reasons for that, but United States is not. We're not the highest in infant mortality. Quality of care of asthma, diabetes, we're down near the bottom. Quality of acute care in childbirth, heart attack mortality. We don't rank first in any of these things, and yet we spend more money per capita to treat these conditions. And I think what we have to realize is there's this quality triangle, all right? When we talk about healthcare, what we're trying to do is get the best results possible, quality. We're going to try to get the best access for the patients, and we want to do it for the least amount of dollars. That's the ideal situation. But we get an imbalance across this for many reasons. And when we have to figure out what we need to do for how we get paid or how hospital systems get paid, we need to think about these three things. Everything in the healthcare system will come down to the quality of care I'm providing as a surgeon or a physician. How easy is it for those patients that need it to access the system? And disparities of healthcare have been brought to the forefront because of the COVID pandemic for this very reason. And how much does it cost to deliver that care? And is the care I'm delivering cost effective? i.e., am I spending a lot of money on a condition I cannot do anything about? And why are we doing that? So, to understand how we are going to get to getting paid, you have to understand how the system came about. This is Louisville around 1910. In 1910, Theodore Roosevelt was president. That's Churchill Downs in 1910. And that is the Marine Hospital, which was a functioning hospital and the precursor to the very building you're sitting in 1910. And I take you back to 1910 because you have to understand what was going on to understand how the system in the United States came about. All right, so that's the Marine Hospital. You can still see that. It actually started in Appalachia, believe it or not. In most of the regions in Appalachia, we had coal mines. We had other areas that were high-risk industries, railroads. And the reason we had those is because the people were being put into the mines, but we had to take care of them. Because if we didn't take care of them, it was a limited resources for getting the coal out of the mountain. And so what we began to do and see is progressive era reforms, what they call in the 1910s and the early 1920s. And it talked about people in factories, and it talked about people in coal mines, and it talked about people on the railroads. And what it said was we have to take care of them because they are the backbone of the industrial complex moving through the Industrial Revolution at the time. So in the early 1920s in Appalachia and other regions, what you found was companies would hire surgeons and physicians at the time to go into the mines to take care of the miners. They would set up clinics so that the miners did not have to leave the mine to get taken care of because it took a lot to move people up and down the mines at that time. So one of the reasons and one of the things that we first began to associate healthcare with work, which is what we do here in the United States, was related to what we were seeing at the time in the Industrial Revolution. Workers' compensation was developed in Wisconsin and Mississippi. Wisconsin was the first in 1911. Mississippi was the last in 1948. And what does that do? Well, that pays you if you're injured at work. In the 1920s, we started to have a more comprehensive, we needed to do this as a federal system. Unfortunately, nothing happened. We didn't pass any state legislations as a federal system or state systems. We didn't pass anything nationally. And so what began as we realized we need health care for individuals who are working because that makes us more productive, began to be tied to the job that they had. Well, in 1929, stock market crashes. So we just begun to associate healthcare with work, and we started to put around 1 in 3 people out of work following 1929 and through the 1930s. And so the Great Depression changed everything. It changed hospitals. It changed the way people went into hospitals. It changed the occupancy rate of those hospitals. And what people realized is that there were people with no money, but surprise, surprise, they're still sick. It's a problem that we're dealing with today. And so at the time, the CEO of Baylor University Hospital enrolled 1,250 school teachers in Dallas. And they said, for 50 cents a month, I will give you 21 days free health care if you need it. And thus the first insurance pool was started. All right? AMA didn't like it because it only carried hospital costs. So the physicians were still at work. And so you start to see the first kind of friction between a hospital and the physician and the surgeon. It moves on into the 1930s. California did this. In 1933, we had 26 different hospital plans across the country, i.e., well, you pay us every month and we'll make sure that you have hospital care. And in 1933, the American Hospital Association starts its Blue Cross Commission to look at this and to look at insurance. And thus, Blue Cross and Blue Shield insurance companies were started. And what we find is this is the first idea that we are going to have insurance, but we need to understand, why did we have it? It wasn't for the altruistic goal of us providing health care to individuals. The reason we have health care insurance, it was a way to keep the hospitals open during the Depression. So we have associated work with insurance and insurance in keeping hospitals open. In the 1940s and 50s, this only grew. And the reason for this is we had a wage freeze during World War II. You couldn't increase prices. You couldn't increase what you paid people. And so when you were negotiating for benefits for workers, one of the things you would negotiate is the fringe benefits, i.e. health care. And so when unions would go to different employers and say, our workers need this, need that, I can't give you more money, but I can pay for your health care. And thus we cemented what we'd started in Appalachia, and that now we universally tied health care and working. In the 60s, we realized, well, there's more than that, right? We had a little bit more of an aging population, and we realized that, particularly as the baby boomer generation, as they got to be known, as they got older, they would need more health care. And people over the age of 65 who were not working prior to 1965 couldn't get health insurance. So the people that needed it most couldn't. And as a country, we passed the legislation, Social Security amendments, that allowed for Medicare. And so Medicare came about as part of Social Security. Medicaid came about slightly after that. In the United States, it's a state-run program for Medicaid for those most in need. So by 1967, we have everything. We've got Medicare, Medicaid, we've got private insurance, it's tied to work, and that's it. Since 1967, despite everything we've done with the Affordable Care Act and what we have done and expanded as far as universal health care, we're using the programs that were set in place over 55 years ago, 60 years ago. So when we look at what we're doing today, we need to realize that the roots of this are really out from 1965 onward, and we're using the same modes of distribution of healthcare that were put in place during that time. Now, so we understand who the players are, we need to understand what the game is, and the game is managing risk versus moral hazard. So let's talk about risk, all right? This was the old risk management. If you're going to fail, make sure you fail big enough you can get a government bailout. But what is risk? Okay, insurance companies want to make sure that we've got a large pool, all right? The reason is if I have 1 in 100 people that spend a lot of money on their health care, for whatever reason, they've got cancer. They've got a chronic medical condition. They've got other things that are going to cost a lot of money. I can then balance that out over a large portion of people that are paying, and I don't get saddled with an unreasonable amount of money. If I don't have a large pool, if I have a small pool, I have to make sure that that small pool of people aren't going to be those high healthcare utilizers, those people that utilize the healthcare system more than others. And that's why insurance in small pools is exceedingly expensive. And so it's very hard to get as an independent practitioner, as an independent physician, as anyone who works without a corporate funding or a business funding for their health insurance. It's very hard and very expensive to get insurance because that pool shrinks. If I don't have tens of thousands, if not hundreds of thousands or millions of people in my risk pool, the chances of one person throwing off that balance is much higher, and the insurance companies charge you more for it. So if we do not have someone, i.e. the government, backing up these pools, then the problem is we're pricing people out of the market, and we're unfortunately pricing people that are vulnerable. So managing risk is what the insurance company is working for. Well, how do they do it? And interestingly, the Rand Corporation, and the Rand Corporation is still around for those that don't know. The insurance companies actually got together, and the Rand Corporation ran an experiment from 71 to 82. They had 2,750 families. There were a little over 7,000 individuals. All were under the age of 65. They participated in about 6 different sites across the United States for about 5 years, 3 to 5 years per average. And what they looked at was insurance when people were seen, what they were seen for, and the like. They randomly assigned these folks, okay, to one of 5 plans. Free care, all right, so this is free care. Everyone gets everything. No matter what, you go to the doctor, it's paid for. It doesn't cost you anything. All the way up to you have to pay for 95% of the cost, all right? So what did they find? Well, surprise, surprise, the people that got free health care went to the doctors. And the people that had to pay for health care did not. So did they take from this that we need to have universal health care in order to make sure that everyone has free access to physicians? No. What we took from this is that we need copays. People have to have skin in the game in managing that risk, right? And the question was, why and how? Well, if we look at those with lower expenditures, what we found that those that had to cost share somewhat had much less expenditures than those that had for free. But when we looked at it from those that had to spend 95% of the pay, it wasn't that different. And what you found was that people that truly needed to be seen would go and be seen by a physician or a surgeon, be seen in the hospital, regardless of what the cost was. But if they could do it for free, they would, quote unquote, overutilize the system. So it was more expensive. And thus leads to moral hazard. Now, we talk about moral hazard as, you've probably heard this in the banking world, right? If there's no risk, then you just can take the riskiest options available to you to make the most amount of money for whatever's going on. However, let's put it a little differently. I'm on call with my resident team, and I'm buying dinner. Okay, so if I am buying dinner versus you are buying your own dinner, if you're going to go and buy your own dinner, you might buy a hamburger because you're residents, right? That's what happens. I get it. I bought a lot of hamburgers when I was a resident. However, if I am buying your dinner, I guarantee you that when you order, this is what we're going to wind up getting. It's the same equation and same problem. It's moral hazard. If you have no skin in the game, there's no reason for you not to get the most expensive thing and ask for the most expensive product. So the bigger question is, it's here, copays are here, having skin in the game is part of what insurance companies do. Okay, did it defer important care, i.e. appropriate care, things that are necessary, things like conjunctivitis, pneumonia? Did it make you not go to the hospital for trauma? Did it make you not go to the hospital for asthma? And the answer is, yeah, it does. It makes you not go to the hospital for everything, whether it's appropriate care, inappropriate care. And I think it's important to realize the patients that we rely on often don't have an understanding of what is the most highly effective care. They don't know what is the most futile care. And so one of the things and one of the reasons it's important for us to understand how we generate our pay, or how a hospital generates its pay, or what physician and hospital services cost, is because we have to be the people that are educating the population that's coming to see us. If we don't take on that burden, for better or worse, we're neglecting the fact that there are populations that will not see us, that need to see us, because they don't know what is important and what is not important. And think about it. Think about all the people that call you and ask you questions as soon as you start medical school. If they hear you're in medical school, suddenly you get to be the arbiter of all the medical decisions of everyone in your neighborhood and everyone you've ever known, right? And you don't know anything more than they do because you've been in medical school for 5 minutes, right? It gets worse. I'm going to warn you, okay? That's the simple fact of the matter, is people are looking for resources. And I think one of the things that, and one of the most important reasons we as surgeons need to make sure that we're involved in these conversations is we need to make sure that we are able to tell people why they have certain things going on, what's the most appropriate care they have, what's the most cost-effective care they have, in order to educate them and get them into when they need to be seen. So as we go through this talk, and there's your background, those are your learning points. As we go through this, I want you to remember that all healthcare insurance, all the plans we have, are about managing risk and moral hazard of the patients. Risk to who, i.e. is a hospital closing, is a physician getting paid, is a hospital getting paid, who's paying those bills, what's the risk of them not being paid, versus moral hazard, who's going to use it appropriately or not inappropriately, depending on if it's free or not. Okay? So remember that as we talk through a few of these things, and in particular in the end, I'll give you a good example of why it's important as we move. But I hear it. I'm a boomer, I guess. So that's 1970s. That's not real. Well, that is real. This is 2019. This is actually just before COVID hit. The Kentucky Health Plan reapproved and scheduled a term for copays for Medicaid. So for those that don't know, even Medicaid funding requires copays in the state of Kentucky. And it's not a lot of money, it's $5, but it's still $5 in the most vulnerable population. So even the states realize that there's going to be cost sharing associated with the healthcare plan. Now the bigger question is, I hear this too, but wait a second, Dr. Smith, we've gone to telehealth, and telehealth broke down the borders, and there's no copays associated with telehealth, and technology is going to save us. Not really. And I think the other thing we realize is that we are already beginning to roll back many of the things we put out as far as telehealth coverage is concerned. Many of the rules we broke down about interstate borders on who can see who are going to be rescinded, to the fact that I sent this email out this week to all healthcare providers. So for those that don't know, effective March 31st, if you have a Kentucky license, you can no longer see Indiana patients with telehealth across the border. You have to have an Indiana license. They're rescinding that. So many of the things that we thought were going to change the healthcare world and were going to break down many of the barriers that we see to access and delivering, good quality healthcare were put in place and are now being rescinded. And we're getting back to the system that we had. And so fundamentally, we still have to make the changes that we are going to talk about. Okay, so there's your background. We've got the players, we know the rules, so how do I or will I ever get paid? Well, let's talk about a few things. So, first thing you need to understand is there's a slight misalignment in priorities in the healthcare system, in case you haven't quite figured this out. Number one, physicians and hospitals do not get paid the same way. All right? How do physicians get paid? So this is the one that everyone asks. So at the end of this, when I have to go and drop a bill for a surgery I did or a patient I saw, what do I need to know? Well, let's start with the first thing. ICD-10s. Okay? ICD-10 codes are taken either from you directly or from what you put, the language you put into your operative notes or into your clinic notes or into your H&Ps to tell what disease or injury does that patient have.
All right, they're descriptive. They're simply about saying patient has diabetes, patient has hypertension. All right, that's it. You don't get paid for an ICD-10, but it informs the insurance companies and the people that are going to pay those bills what is going on with the patient and what's associated with it. I've put some of my personal favorite ICD-10s up here, and for those that are interested, you can actually search the ICD-10 database for interesting codes. Here's a good one: sucked into a jet engine subsequent encounter. So the good news is the initial encounter, you never quite know if you're going to make it, but you've got follow-up covered for sucked into a jet engine. Pedestrian on foot injured by collision with roller skater. That's a good one. Burned due to water skis on fire. I kid you not, it's a real code. It's a real code. And struck by a macaw. Point being is there are over 70,000 codes in here to describe what is going on with your patient. All right? It's complicated, and it's complicated for you as a physician to understand what's going on. So we often hire people called coders. All right? Coders will go through this language and see what you wrote and try and figure out what code matches best. However, here's a slight problem. Do you all know who's responsible for that coding? The coder or you? You. The person that's writing it and putting it in is attesting to that coding. So when we hire someone to do this coding for us, we're at risk if they code this wrong. So you have to keep an eye on what you're writing and what you're doing. And the good news is that once you begin to start using many of these codes over and over again, you begin to be able to put the language in that you need to get them, or you can put the code in itself. The second thing you need to understand is CPT codes, okay? Particularly if you're going into a procedural specialty, surgery, orthopedics, GI, what have you. Current procedural terminology, or CPT codes, come out every single year. There's new ones, right? They were developed by the AMA in 1966, and 1982 is how they actually started getting valued for insurance claims and the like. But there are three categories. The one that really matters is Category 1. CPT codes in Category 1 basically tell you what you are doing to that patient, i.e. what procedure did I perform? It's a numeric code. 4700, for example, is exploratory laparoscopy. There are literally tens of thousands of CPT codes. You have to put one of those, or someone has to put one of those at the end of every procedure or bill that you drop to say, I did this, here's the code for it. Because the insurance companies aren't going to look at the language, they're going to look at whatever code is associated with it. So I now say that a patient has been struck by a macaw, and I had to do an exploratory laparotomy to get the macaw out of their abdomen. All right, so I've got an ICD-10, and I've got a CPT code. All right. From there, you think I send that to the insurance company and they'll figure this out. And not yet. So for every CPT code that we send in and we put in as far as a procedure, or from our standpoint, you can look at E&M codes, similar to that. That's management codes up on the floor. We're going to assign a value to that called a relative value unit, RVU. You probably have heard people talk about RVUs before. Okay? The idea is that I can take a spectrum of services from a pancreatic duodenectomy to an office visit and assign a numeric weight or number to that so that people can understand how much work it takes to do those different things. Now, RVU has a lot of components to it, right? And so it gets even more complicated, right? So an RVU typically has three components to what it is, total RVU. There's the work component, work RVU. That basically is telling you what the physician did, all right? Work RVU is about half of what a total RVU is. You get the practice expense, how much it costs from a practice perspective to provide that care. This is supposed to account for things like Band-Aids and 4x4s and needles and the like. And then you've got a malpractice RVU, i.e. how much it costs to do the business of doing what you're doing. I.e., if I have to pay a lot in expenditures for malpractice insurance based off the state I am in, I will thus have a slight increase in that RVU. As you might imagine, that changes. So depending on what state I am, the malpractice component may change. The practice expense may change depending on where my practice location is. And on top of that, you get paid more for doing it in the Northeast than you do for doing it in the South or the Midwest. And that's called these geographic practice cost indices. Now, if that sounds complicated, it is. What we have to realize, and what you need to realize, is there's one stable component of this, which is called a work RVU, or WRVU. That tells you what you as a physician did. And the reason I say that's important is because many contracts, instead of looking at total RVUs and the way you compare them, just actually look at what the work RVU component of your job will be, because that's not going to change. A work RVU in Boston for doing a pancreaticoduodenectomy is the same work RVU in Louisville, should be the same work RVU for doing Dallas. And so when we look across those different areas, that allows us to compare apples to apples and oranges to oranges when we're looking at contracts. But you have to understand that, because total RVUs change depending on what city you're in a state. Total RVUs are different, for example, between Lexington and Louisville, for those that don't know. Total RVUs are different between Louisville and Cincinnati, Louisville and Indianapolis. So being aware and understanding what these different terms mean and the portions that go into them are going to be important. So I've got an ICD-10, I've got a code, right? I've said why they've done it, McCall. I said I've done the exploratory laparotomy, 4,700. For those that don't know, 4,700 is about 15 or so work RVUs. What do I do, and how do I compare that? Okay, so let's take a look at this. These are CPT and E&M codes associated with inpatient and outpatient visits. And you can see that if I bill for critical care time, it's about twice as what I would bill for a new patient visit on the inpatient side of things, and about 4 times what it would be for an office visit. And we've talked about this. I think, if I look at things like lap appendectomy is 9.45 RVUs. It's about 10 times harder to do a lap appendectomy than it is to do a office visit, all right? Pancreaticoduodenectomy is worth 52.85 work RVUs. If you're wondering, one of the highest we do is actually packing the liver or hepatophy for a trauma is worth about 85 work RVUs. I'd rather do that any day than a pancreaticoduodenectomy, but that's just me. But you can look at it, and I think the important part, and one of the things that we've shown, and Dr. Scoggin showed when he talked about our own practice, is transparency. The way that people do well and understand what's going on is if you're transparent about what you're looking at, what everyone's doing, so people understand why they're getting into the situations they're getting into and who's getting paid what because of the work they do. So when we start talking about, figuring out contracts or figuring out what you need to do, one of the things you need to look for is transparency in that contract, okay? So we've got our ICD-10, we've got our CPT, we've got our work RVUs assigned, so it's time to get paid, right? Yeah, hold on. Do you know how much you're worth? That's Terry Pratchett, for those that don't know. For the record, 100 kilos of gold is $6.15 million. I think Dr. McMaster would probably sell me for $6.15 million. But do you know how much you're worth? So if I say, hey, you should make X number, you should do X number of work RVUs. If I said I wanted you to do 20,000 work RVUs, is that right? Well, you don't know until you start looking. And so when you start looking for how much I should get paid, you have lots of different things to look at. You've got the MGMA, you've got AAMC, you're looking for fair market value. But basically what you're trying to find is a salary and benefits survey from whatever year you're looking at for surgeons to figure out what the average surgeon makes and what the average surgeon does, okay? So let's talk about 2 of the most important. MGMA is the first one. Medical Group Management Association. So the way this works is they send this survey out to lots of different people, and it's a voluntary reporting of the survey. You send back what you make. You send back what you do. They correlate that and put that into your specialty and put that into location, and they break it down in percentiles and send it out. It's fine. It actually is a good starting point. I will tell you, it is almost universally high. Anyone know why that might be? Well, I'm voluntarily reporting. I'm not going to tell you I don't make jack. I'm going to tell you I make a little more than I make, right? Or I always work a little harder than I'm working because I'm trying to get the numbers up. So if I look across the board, MGMA, for example, when you're looking at it, it's almost universally high when I look at what physicians make in different areas. Now, it's not universally that way, but it is in different areas and different parts. Okay, well, let's look at AAMC. So for those that don't know, AAMC collects data from the deans and from the business officers at different medical schools and healthcare settings on what physicians do from a work RVU perspective. They also look at how much they make. I will tell you that AAMC is almost universally low from that regard. So, which one do you look at? Some of it depends on what practice you're going into. MGMA in general correlates a little better with private practice surgeries in larger cities. If I'm looking for an academic thing, I may look for AAMC type data. But looking and getting information from some of them is going to be important because there are others. There's Merritt Hawkins, there's Sullivan Carter, there's HSG. There's all kinds of different people that put these reports out, and they all want you to spend around $1,000 for every single report you get to get this information. But what you're trying to find out is, what is my fair market value? What do I need to make? What kind of work do I need to do? How do I need to figure out how many work RVUs I need to produce to get the salary that I need? The way to figure out how you get paid. I think the important part is that you remember practices vary greatly. And as is Dr. Coleman, with Dr. DeMoya, has looked at this for trauma surgery. So if you want to see the link, that's the link up there. But what they were trying to identify in their most recent paper is trying to figure out, in different level trauma centers, what does it mean to be a 1.0 clinical FTE? What does it mean if I've said I'm a trauma surgeon? How much service should I do? How many weeks of service do I need to be on? How many times should I be taking call every month? How many operations should I do? Do I have general and private practice as part of my compensation? You know, how much do I average on call for pay? Those type things. And they took a look at the different areas of service, level 1, level 2, level 3, and they tried to identify, was there a difference between those? And what does it mean, and how do you quantify what a 1.0 FTE is? I will tell you, this is the first time we've actually tried to do this in trauma and critical care. I guarantee you we probably are not the spear point, but we're pretty close. And I don't see a lot of this information getting out across the different areas of medicine and surgery. The other thing they looked at is, what does it look like for your practice? I.e., how many surgeons are in your practice that are typically doing these things? So, in a level 1 trauma center, how many surgeons are typically covering a level 1 trauma center? Is that about 9? If you look an average across the board. So this gives you an idea of the work that you need to do, and how do you standardize that work to getting paid. So we send a bill in with a work RVU, and we need to figure out what we're going to do with it. Now, there are lots of different contracts, and I could spend another hour talking about different ways of being paid, but the important part that people need to realize when we do this is that contracts are very different across the different areas. And no matter what you look at, you may get paid a salary and be expected to provide a certain amount of work RVUs to the group, and they will pay your salary. In general, that's how most contracts start. That's a guarantee. You start off and you don't make very much because you're brand new, but as you grow in the first few years of practice, you begin to become busier and busier until you're making your salary. Some contracts are straight up paid. I'm going to pay you $53 per work RVU, and whatever you bring in, you can get paid that. Or some are more of, well, I'm going to pay you whatever you collect per work RVU. Okay, as long as you understand what the underlying mix of your patients are, who's paying and who's not paying, that gives you an understanding of how I'm valuing your service. But it's more than that. It's the other parts that go into managing a practice. Now let's contrast that for just a moment for how hospitals get paid. Hospitals get paid completely different, okay? Hospitals get paid by something called an MSDRG, right? Medicare Severity Diagnosis Related Group, DRGs. Now, what you need to realize is the DRGs take everything, an ICD-10, a CPT code, they take the complicating factors, they mix it all into something and give you a 3-digit code, okay? That 3-digit code, there's around 700 or so different 3-digit codes for DRGs. There's a dollar value associated with that. For example, a DRG for tracheostomy, which is always an interesting one to look at, pays around $27,000 to the hospital. Someone who gets a tracheostomy, the hospital should get around $27,000 for that hospital stay. Why is that? Well, because it takes a lot, and the people that get tracheostomies typically require a lot of care. So hospitals, for example, are looking for patients with tracheostomies, because even if you're here for 4 days or you're here for 40 days, they're getting $27,000 for that care. Thus the reason to move people in and out of the hospital very quickly. Prior to adopting DRGs in the 1979 to 82 timeframe, hospitals did not get paid this way. Okay? Hospitals got paid per diem, i.e. the more days you spend in the hospital, the more money the hospital got. But when DRGs came about, it was a way to restrict hospital costs. So all of a sudden now, no matter if you're here for 40 days or 4 days, you get paid the same amount. So what does that mean to the hospitals? Well, that means you're not staying. And thus the days where you would come in and stay a week for a hernia operation, for an inguinal hernia, are gone. And now it's an outpatient procedure. Okay, that doesn't sound horrible. It's a way of reducing cost. Well, what are the challenges associated with it? And this is a great comic, because what you have with the introduction of DRGs are the mix match in the system. And that the DRGs that pay well, i.e. a healthy person that needs a knee replacement, a healthy person that needs a hip replacement, someone who's coming in for elective procedures, are going to be prioritized by a healthcare system over things that take a lot of resources and money to take care of, right? So heart failure, chronic medical conditions, trauma, all of those things are highly needed within a healthcare system, but comparatively, they're difficult to benchmark. I take something like a traumatic hip fracture for a DRG. It pays somewhere along the lines of $18,900 for traumatic hip fracture. Now, what if that traumatic hip fracture is associated with a TBI, right? So now all of a sudden that traumatic hip fracture is going to stay in the hospital as its primary diagnosis for 21 days, give or take. Whereas if it were really a fall from standing with a hip fracture that may be here 3 days, it's difficult to quantify. If I have to spend a lot of resources in the outpatient management or the coordinating of care, i.e. someone who comes in and decompensated heart failure for the first time, there's not a lot of money in the healthcare system or hospitals in order to pay for that. And so you wind up with this strange mix, i.e. DRGs, or the idea of DRGs are supposed to reduce the overall cost of hospital expenditures, but what we come to is that DRGs also begin to select for particular procedures, and healthcare systems begin to select for particular procedures that are well compensated as opposed to what the difference or what the community needs to make their differences. And so we come to this system where you and what you code and what you do make a big difference in what the hospital gets paid, but it's not always in line with what's best for the hospital, even though it may be in line with what's best for the patient. And so the hospitals may not value that very well. So is it really this bleak? Well, hang on a second. So there's one more thing, and when we talk about the future of healthcare, this is one I always kind of bring up and then I'll stop on. Bundled care payment. So for those that don't know, something coming down the pike is bundled care payments, okay? I.e. if the hospital and you come together and say, we're going to get $25,000 for hip replacement. And that's going to take care of that patient from the moment they're seen in the physician and surgeon's office all the way through to their stay in the hospital to when they're seen in post-op care. And we'll divide that up, okay? Well, what does that mean? Well, now all of a sudden, that shifts even more risk to the hospitals, and the hospitals then shift even more risk to the surgeons, right? So it's all about managing the risk to the insurance companies and the hospitals. That's what they're looking for. So when you're worried about and thinking about how you're getting paid, what you need to realize is that you need to take a look at your practice. Where does it fit into the healthcare system? What do they value? Or is your practice valued? And how you're going to be compensated for the work that you do. So is it really that bleak? Well, the answer is no, it's not. I'm giving you different ideas and different opinions, but I think what you need to realize is that we are in a bit of a nadir. And I think I put this up in one of my other quality things before. We're in a dip, and that's why I say we are in a crossroads. Because as we move forward, what we are going to have to do and what we're going to need to begin to do is really start looking at healthcare system compensation and physician compensation along the same lines, and begin to line that up with what our communities actually need. And COVID has kind of brought that to the forefront. It really has taken the idea of the disparities of care that we see in our neighborhoods, disparities of care we see in our systems, that we need to begin to look at embracing that and fixing those underlying problems. And we understand that if we can fix some of the underlying problems associated with this, we can decrease the cost of many of these things that are not cost effective for the hospital system. I.e., if I can get out and help a neighborhood that is underrepresented in healthcare professionals get patients with diabetes under control, fewer patients are going to show up to my emergency department and require admission. Fewer patients are going to come into the healthcare system that are going to cost me more, so I have more time to do other high dollar things from a hospital perspective. So there's a way of getting funds to where we need them to be. But we're just in the beginning of that. And I think it's important when we talk to the students and the residents and the fellows who I gave this talk to previously, you need to understand what's coming down the pike. And I think most importantly, you have to be involved in this. You have to begin to talk about money. You have to begin to talk about making sure that we are providing for the patients that we care for and the communities we care for. But underlying knowing and understanding how we get compensated and what we need to get compensated in order to be able to provide those services. So there's nothing wrong with talking about money and funds. It's part of what we do. We need to get over the stigma that we shouldn't talk about it, or it's dirty, or it's wrong, okay? Be a part of the conversations with your healthcare organizations. When you're signing your contract, be a part of those conversations with the groups that you're going to be joining. You know, if you're going to come work at someplace great like here or someplace horrible like, UK, you can make those determinations on where you're going to make a community. Because that's important, because that's going to be important for the future health of our systems. It's going to be important for the future health of you as a surgeon. And I'll give you one last thing, even though I spent the entire time talking about money. Do not measure your worth in only gold, okay? It's important, and it is an important part of what you do. But it's not the only thing you do. We have plenty of things that we give back to the community, our families, our friends, that are important parts of what we need to evaluate to make decisions on contracts, okay? But don't neglect the compensation that you need to get in order to make those decisions. And I think that's what I want to get home to you all at this first, I would say, this overview. And we can have other discussions and happy to answer questions about contracts and the like. I see, I'm lucky enough now that most everyone who signs contracts brings them to my office before they sign them, no matter where they're going to go, and we talk through them. But think about where you fit when you're signing contracts. Think about the fit for you in your practice in the healthcare system, and think about where that healthcare system fits within its community to make sure that you've got everything outside of the dollars taken care of from your professional world so that you can have a good private life and then also be compensated fairly for what you do. So with that, I'll stop and happy to answer questions. Thank you all very much.
Thank you, Dr. Smith. I think for luck that happened to dovetail nicely with what I was trying to talk about last. To your last point, most important thing for those of you who are going to be looking for your first job is clearly you can take a job that'll pay you a lot more money. That's the least important thing. The most important thing is that you find a job where you're going to respect and admire your partners and the people with whom you're working, work with a team that you enjoy working with, you feel part of something valuable and you're doing the right thing for your patients and able to take good care of patients, and that you don't, you can get a job where you become the solo surgeon in some rural county by yourself on call 24/7. That may be what your career aspirations are, and that would be great, but if you're doing that for money, you won't last very long. Find a stable place to work that will allow you to grow and have good mentors and partners, because you learn throughout your entire life. That's much more what the dollar figure is. Dr. Smith made a lot of very important points and observations, but I think for most of you, there's been a fundamental shift that's happened in the past decade. And not very long ago, we even at the university, we were managing a private practice based on the actual dollars we collected down to the penny, distributed to the doctors in some proportion to how they earned it, collected it. That's even shifted for us. None of you are going to be in private practice, virtually none of you. You're all going to work for healthcare systems, either a big university system or another healthcare system, and you'll be paid, at least for the time being, per work RVU or according to your contract that includes, in many cases, some productivity metric per work RVU. Value-based reimbursement, although we've been talking about it for a long, long time, has really not taken hold, and health systems still pay you for the amount of work that you do that's based upon, for lack of a better system, the work RVUs. So what Dr. Smith described, this whole work RVU system, is how you're going to protect or enough. Important that you have some understanding of how that works. But probably the days where you're going to be having to be responsible for coding, billing, collecting, and down to the penny, how all that works, probably not as much as people used to. Mm-hmm. Dr. Smith, your comments.
No, I'd agree with that. And I think part of that too is you still have to understand the system. And while most of you are going to work for a healthcare system, Dr. McMasters is absolutely correct. You still need to understand, what you're being judged for and what you're being asked to provide. And is it fair market value? I mean, is it fair for you? And it's a part of what you need to look at in these contracts. And so understanding the different terms I talked about and understanding the different areas where you can get that information is really what I'm trying to get through as far as this overview. There are resources for you, not just, call Dr. Smith or call Dr. McMasters and ask the questions. There are resources out there that can get you that information as you look at contracts and begin to look for your first jobs. Because as Dr. McMasters said, pay is only a part of this, but it is a part you can't neglect. You can't just say, well, as long as everything else is there, I don't really care what I get paid. Because the end of the matter is you do, whether you believe it or not, you will. And so you want to make sure that you feel fairly compensated. And I think most healthcare organizations want you to be happy, and they want you to feel like you're fairly compensated for what you're doing.
Yeah, what people don't like, is everybody gets paid the same, which is one compensation system. Everybody gets paid a salary. The people who do, there are always people who do a lot more work and people who do a lot less work. The people who do a lot more work never feel quite right about it. Less work always feel like they're getting away with something. And there's always got to be some measure of being able to compensate the people who are doing it. But the right way to do that isn't always. Dr. Bozeman.
One of the questions of the 90-day global period,
Mm-hmm.
like what's the difference between before and after versus daily routing charges?
Yeah, so just for everyone online, the question is about the 90-day global period. So different procedures have different global periods. So those that don't know, there's actually the 0-day global period, there's a 7-day global period, there's a 90-day global period. So you need to understand what the procedures are that have those different global periods, particularly in your practice. When you get out into practice, in general, you're going to do, from a surgical standpoint, about 20 operations. Some people will do more than that, but most people are only going to do somewhere between 7 and 20 operations, and you need to understand what that is. In general, for a global period, any care that's related to the surgery or the procedure you're performing is going to be part of that 90-day global period, i.e. all the follow-up appointments you have. If you're looking at a wound, you're changing a bandage, you're managing nausea after general surgery, what have you. However, anything that falls outside of that is not part of that global period. So if you have a patient that comes in that is in hyperlipidemia and you're having to manage that, or you've got someone who's got asthma, but you happen to have them admitted and they're in the hospital for asthma, but you just did an inguinal hernia repair, those are all things that you can, if you're managing them, can bill for because it's unrelated to the procedure. So the one I always get asked about is electrolyte abnormality. post-op. So technically, if you're managing an electrolyte abnormality post-op, you can bill for those services, and that allows you to bill for that next day. So it's just understanding what the global periods are and what that care that you're providing and how you espouse that care related to the procedure that you perform.
So when you might not have to be as involved in the business side of all of this as some of us as we used to. You, as Dr. Smith just said, clearly are going to need to understand how to appropriately document for the services you provide for the evaluation and management office and hospital, how to get reimbursed for those when they're reimbursable and understand the rules, and understand how to code for those things and for the procedures that you do most commonly in order to be sure that you are doing your part to show your value to the healthcare system, because you can maximally reimburse, or the system gets reimbursed for the work that you're doing. If you don't appropriately document and don't appropriately contribute to that coding, documenting your operative notes and in your clinic notes and floor notes, then you're losing money for the healthcare system and you're losing value that you demonstrating. Scoggins, your name's been invoked here. Do you have comments, questions?
Yeah, James, I thought that was really great, and a topic that is not entirely sexy, but certainly you hinted on the concept of hospital margin. Even though you didn't. Mind touching on that?
Yeah, so the question is about hospital contribution margin. Absolutely. So I didn't get into it because there's a whole lot that goes into how hospitals get compensated. But one of the things that's important to understand is, let's say we take a lap chole. You take something like a lap chole and understand, okay, well, what do I get paid for a lap chole as a hospital system? So there's a DRG related to laparoscopic cholecystectomy, and you'll get paid whatever that DRG is. Well, how much do I actually spend to actually perform that lap chole? And in particular, one of the things that we're beginning to look at, even in our own healthcare system, is the variability. So Dr. Scoggins does a lap chole and he spends X amount of dollars. Dr. Bozeman does a lap chole and he spends 2X amount of dollars. Why? And each case is going to have something along those lines. That's called a contribution margin. So if I have a DRG that comes in and I know that the DRG is $20,000 and I know that it costs me $10,000 as a healthcare system to pay for that care, I can say our contribution margin for that DRG is about $10,000. It may be more, it may be less, depending on who's doing it. And I think understanding that variability and understanding what you're doing in the operating room, particularly around technology, is important. You look at things like the robot. Using a surgical robot is fantastic. I think it's changed a lot of different operations, although you can plus or minus that sometimes, but I do think it has. But it's insanely expensive for what you're doing. And anytime you do something with a robot that could be done less expensively with the same outcomes, you have to really start asking yourself, is it worth it? Because that money is simply going to an outside entity, not a hospital, not a patient, and not a physician. And so you have to really start looking at the cost of things that you bring into the surgical suite, for example, that are going to change the contribution margin. And is it worth it? And if it saves a lot of time, maybe it saves you a lot of time in the operating. Okay, fantastic. There's a dollar amount for that. Or maybe it gives a much better patient outcome. Okay, there's a dollar amount for that too that's worthwhile. But you have to figure that out as you're kind of looking at different procedures and contribution margins associated with the hospital. Dr. Polk. Sure. So resident salaries are not derived this way in any way, shape, or form. So, so resident salaries, there's two components of a resident. Luckily, about 2 years ago, we were able to increase that. But resident salaries are typically coming from Medicare, and there are dollars associated with that, something called the cap. There's a number of procedures or a number of residency slots that the government pays for in order to train that. There's an instructional component, something called IME, so the GME, the graduate medical component. There's something called IME, the instructional component that comes to the hospital that's supposed to help pay for the training spaces and things like this in order to have conferences and the like. But up until about 2 years ago, that was capped. So that money came through, and it would come to the hospital, and the hospitals would dole it out and sponsor the residents depending on the number of residents you had. A couple years ago, we actually in Kentucky got rid of the cap, and so now we can pay for them through Medicaid. Prior to that, if you didn't have a hospital willing to sponsor you or the government willing to pay for you, there was no way to have a residency position. So if I needed to add a resident to University Hospital, the hospital had to pay for that resident salary, benefits, and the instructional component. And in general, it's a good investment. I mean, not all of them. You can look back in the back, but most of them are good investments, right? A couple years ago, we lifted that here in Kentucky and got rid of that cap. And so now we actually get dollars through Medicaid. So we can actually take a look within the state in areas that we need more residents, family practice, internal medicine, things that generally aren't paid well for the hospital. We can actually bring them in, and Medicaid will help pay for the resident salaries and training of those individuals. It's a set number, so I laugh. Every time we give the residents a raise, that number's not going up. The amount the government gives us doesn't change. But in general, it covers right now, it covers around 90% of the resident salary, and the healthcare systems and the hospitals kind of eat the rest of it because it's worth having you all here. It's worth training the physicians of the next generation. And I think all of us take that, the VA, Norton, ourselves, Baptist somewhat, take that into consideration and as being a good investment in the future.
Yeah, don't let Dr. Smith fool you. They're making.
Correct. Yeah, I think that's one of the problems you have. So Kentucky luckily has opened up the number of residency spots we're allowed to have, but that's not every state. And I think that's one of the issues we have is you've opened up a pipeline for the number of students coming in, but you haven't opened up a significant pipeline of the number of residency positions available, because unless a hospital or a state has decided to fund them, they're not there. And so that has led to a mismatch. And I think you've seen that for the last couple of years with some of the match rates and some of the number of graduates coming out. So there is something we need to do as far as fixing that, because we know we need to change that pathway and that pipeline. We need to begin to expand those capabilities as we move forward.
All right, we'll take a 5-minute break, then we'll do QI.
Thanks, everyone.